White House announcing a deal with Eli Lilly and Novo Nordisk to slash prices of obesity drugs. Joining us now with the details, Dr. Mehmet Oz, the administrator for the Centers for Medicare and Medicaid Services. And we've seen a couple of instances of this, Mr. Secretary, and thank you for joining us. We appreciate you. I guess I should call you Mr. Administrator, not Mr. Secretary, but we appreciate you. That sounds weird, doesn't it? I'm going to call you Dr. Oz. Everybody knows that. Dr. Oz, I want to talk to you about really what Democrats want to open the government, but let's talk about this first. Is this a template for what we can do with a lot of different overpriced pharmaceuticals, if they are overpriced?
Let's set the stage, Joe. I know you know this, but for everyone who doesn't appreciate how much of a ripoff we've been living through with global freeloading, the president adamantly has been saying that he will no longer tolerate the American people paying 3 times more for the exact same drugs made in the same factories, put in the same bottles, in the same boxes as folks pay in Europe. And so this most favored nation drug pricing strategy has resulted initially with a leading U.S. company, Pfizer, then a leading European company, AstraZeneca. Then we did all the fertility drugs. And today, maybe the biggest of all, because it's the single largest category of drug spend in America, these GLP-1 weight loss drugs. And the reason yesterday that we embarked on this voyage of trying to share with America why this is such a critical opportunity is because if you're sitting in my seat, if you're administering Medicare and Medicaid and the exchanges, you need to figure out how to bend that cost curve down because they're increasing at 7, 8, 9%. And that's 3, 4, 5% faster than the economy is growing. So we've got to find a way of actually bringing the real costs down, not just throwing money at it to reduce what consumers pay, but actually bringing down total cost of care. And if you're going to drop drug prices meaningfully, you'll do that, but in particular in this category. Because of all the things we can do, Joe, reducing obesity in America not only buys us a lot of health, but it also reduces the healthcare spend. We estimate that obesity by itself probably explains a quarter of the total healthcare costs. And so by using these medications, which on average can drop your weight 15, 20% over the course of a year. And again, obesity is not an absence of GLP-1s. You have to use diet, exercise, all the MAHA elements that Secretary Kennedy speaks of are vital to this process. But part of making life easier, making yourself healthier, and making it easy to be healthy, which is what MAHA is really about, is using medications if they're effective. So most Americans would consider this if they were overweight, and a third of us are. Unfortunately, most Americans can't afford these drugs. They're $1,200, $1,300 a month. So in this deal, we are reducing the cost on average to about $250 a month. And if you're on Medicare, which I administer, you're going to pay $50 copay, and government will pick up the rest, and we can afford that because at that price point, within 2 years, it'll be cost neutral. It'll save us so much by reducing downstream problems of obesity like hypertension and problems with the diabetes and even bigger problems like renal failure, strokes, heart attacks, dementia, that we'll actually start saving money. And if you're on Medicaid, it'll be free to you, which is still okay because governors have a moral hazard right now. Obesity is rampant in underserved, vulnerable populations, but they're the ones who benefit the most as well and reduce costs when you do that. So we'll actually help state budgets by driving down these prices.
The narrative of the pharmaceutical companies, doctor, was that the way Europe offered these drugs at much lower prices was basically price controls. And, the innovation is done here in this country. And in this country, we allow companies that spend a lot of money up front on research and development of these great drugs, we allow them to recoup all that investment. Whereas if it was in Europe and you don't allow them to price the drugs to where you can actually benefit from all your research and development, there's not as much innovation over there. And if we import those price controls here, the argument is from the pharmaceutical industry that they're not going to be able to afford innovation and testing on new drugs. Is that totally false, or is the truth somewhere in the middle?
I think that specific narrative is false. And my evidence for that is all these drug companies, Eli Lilly and Novo Nordisk, are well-run companies. Their CEOs were in the Oval Office. They came there willingly. They were not hostages. They've all signed these deals. Pfizer did too, AstraZeneca as well. The argument that we're making and they're agreeing with is that it's inherently unfair for us to pay 3 times more. We still pay most of the money for development. But I hear the concern that we need to be able to innovate. And so if you get Europeans to pay a bit more, We can pay a bit less. Also, some of the areas we're giving opportunities to companies include giving them access to larger populations by making these drugs more affordable. But Joe, here's the real conversation. You sit in a room with these executives, you look them in the eye and say, you went into this business because at some point you really cared about people. And as an American, and in the case of the Eli Lilly CEO, he said, you really want to have your legacy about making an innovative medication class that is changing lives accessible to everybody. It's the most American thing we can do. It's about fairness. And the president has adamantly been pushing this narrative because most Americans get that story. I'd also give you a better metaphor than what you were saying. I think it's more like NATO. We have external threats. Everyone's got to chip in. How much they chip in is the question. Yes, maybe we'll pay a bit more in some instances to get the innovation there, but we all have to defend ourselves. NATO countries are chipping in more. We're asking the same thing right now for an internal threat, disease, illness, cancer. And I'll share one big secret with you. If you have an advanced cancer in America, your survival numbers are better than if you're in Europe because you actually get access to all these drugs. There are no price controls here. The market moves this. We're making it easier for companies to say yes, to bringing their prices in line with what other countries are paying. It's fairer for America, but it's also more sustainable for these pharmaceutical companies. And that's why, in general, their stock prices are staying strong. Investors realize they want stability in the markets, and they don't want government coming down hard. These are negotiated settlements, and I've got news for you. There's a dozen more companies waiting in line to come down the pike to have their prices align with what the rest of the world is paying.
Thank you, Doctor, for that. You're going to have to fix the healthcare system in the United States or make the Affordable Care Act actually affordable instead of the unaffordable Care Act. Let's talk about this government shutdown. So we know it's a clean CR. It's the same funding that the Biden administration was doing. The government should have stayed open. But the Democrats, maybe they have a point, that people need to, obviously, people that are going to have their subsidies double or triple, it's something that resonates with people. And that's why you can't even find, you would think if a party closes down the government to get something that they want through extortion, you would think that the Republicans would have the upper hand. That's not what it is because the healthcare system is so broken, and I guess the rap is that President Trump talks about alternatives. Republicans talk about fixing the healthcare system, but right now Obamacare is all we have, and it's important to the people that have it.
Well, Obamacare is a program I manage, and I'm going to take care of it. Just to put it in context, the average person in original Obamacare, which is folks making between 1 and 4 times the poverty level, their average premium is going to be $50 this year. We know that because the numbers are already out there. Healthcare.gov is already, the marketplace is open. People are signing up. So its average premium that you have to pay out of pocket is $50, and that's $13 more than this year. So in that original population, there doesn't seem to be a huge issue, and we're not hearing huge complaints. The added benefit that occurred during COVID, and again, we're not talking about the actual subsidies to the ACA, to the exchanges. They're already there. They didn't change. There were additional subsidies added that took the support from being 80% of your cost of care to 90% plus. That's the part that's being disputed. And that really hits hard at what's called the cliff, when you get above 400% of the poverty level. And there's a little bit of a hazard here because if you look at all the examples that you see in the newspapers, it's usually a 62-year-old who has a $150,000 pension. That's more than 4 times poverty level. And so they retired early because they could crutch on the Affordable Care Act insurance program subsidized by the government. And now they can't retire early. They've got to wait till Medicare, the other program I administer, for that reason. So I completely feel that pain. And that's really the area that most of this debate is about. But you've hit a very important issue. The real concern is the total overall cost of care in medicine. It's just increasing too much. And the real salvation to this is not going to be throwing more money at premium dollars or enhanced premium dollars or COVID era enhanced premium dollars. I mean, after a while, it becomes hard to keep up with how many subsidies there are. We have to actually reduce the underlying cost of care. That's why in the One Big Beautiful Bill, we did offer some solutions. There was something called a CSR that would have naturally brought down premiums in the exchanges. It was rejected by the Democrats. They didn't want an answer. And that's why I think this is being used as a political tool. The things we need to do to truly reduce cost of care, the Democratic Party doesn't seem to enhance. They just want government to pay more for it. It's not a long-term sustainable solution. And just like we did with the most favored nation drug pricing with pharmaceutical companies, you've got to come to the table with solutions everyone rationally thinks can make sense long-term.
But
what we
Dr.
did in One Big Beautiful Bill was bend the curve for Medicaid. We've got to do the same thing with the ACA.
But Dr. Oz, I think the big question is ultimately how to do that and what that really looks like. And not, I mean, we can take the government shutdown piece of this out of the situation. But if you were king for the day, and I know President Trump has been talking since he was president last time about trying to fix things meaningfully, do you think you could ultimately reduce costs and provide better service? Is that even possible, or do you think it's just a fundamental change in expectations that has to take place?
Well, it is absolutely possible to reduce costs. I'll give you two concrete examples. Over 10% of the $1.75 trillion that I administer is fraud, waste, and abuse. That we can deal with, and we're getting aggressive. And just this week, we put out a rule to take out $23 billion of what we believe in often was not well-spent money with these skin substitutes that are no longer going to be sold the way they were, where you actually literally pay doctors an extra 6% if they pay the most expensive version of the product, not the products that actually are selling in Europe for fractions of the price. And the second big issue, which will probably take the healthcare costs down at least another 10%, is by truly empowering beneficiaries with information. Every other industry you talk about, as, for example, AI you were mentioning earlier, all these industries benefit, whether you're Uber Eats or Uber itself or streaming videos, they benefit from AI supporting the system. Banks work better that way. We haven't brought those tools into medicine in a meaningful fashion, and we have a digital transformation that we are heavily embarked on that will allow us to bring those same efficiencies into the healthcare system. And by empowering patients at the time of care with better information about what they ought to do, by nudging them with insights that can help them with chronic illnesses, by giving doctors incentives to use these tools and giving them also the better ability to manage their care as medicine rapidly advances with better tools that cost less, we reduce costs. And the most important message I have is bad care is expensive. You pay someone to do a bad job, you pay someone to fix that bad job, and you pay for the complications. So the most important thing we can do in healthcare to reduce costs is improve the quality, and this president is committed to this. The Secretary Kennedy will not take no for an answer. That's what MAHA is really about, and I'm passionate we'll get to the finish line.
Dr. Oz, just to bring the conversation full circle since we started at GLP-1s, I'm just curious about one component part of this, which is how quickly do you think that the GLP-1 drugs are actually going to improve? I mean, one of the things that a lot of people worry about is muscle loss and all of the sort of component part issues in that. And I wonder whether, I mean, as you think about trade-offs and also what you think we're going to learn about these drugs and how they work over time.
The field's advancing rapidly. I learned yesterday, and I'll break news with you here because I had the CEOs cornered in the Oval Office. We're going to have pill versions of these on the market by March. Marty McCary, who runs the FDA, is going to fast-track these approvals. And so we're already looking at a new generation of solutions. We estimate that the American people will lose about 135 million pounds over the next year with these solutions. And we are also optimistic that within 2 years, they'll pay for themselves, as I mentioned, just because they're going to reduce some of the healthcare expenses, right. But they're also going to be made in ways that reduce the muscle loss, some of the side effects, the anorexia. Right. But, you know, Aaron, there's other benefits as well. There's a reduction in addictive behavior. I mean, there's less online shopping. So there's other opportunities for this family of medications that go far beyond just overeating. Right.